Miami Community Health. I'm Dr. Anthony Gonzalez here for another important health topic. We're here to talk to you today about healthcare providers. Have you ever heard of an APP? Well, you think an APP may be an app, right? No, we're talking about an advanced professional who's with physicians all the time, helping them in caring for patients. Maybe a physician's assistant, a PA, maybe a nurse practitioner. Many patients see nurse practitioners and PAs in their offices or in the hospital. And I've brought our physician's assistant from our practice for like 15 years who's been with us, Chris Garcia, our physician's assistant, to talk with us today. Welcome, Chris.
Thank you very much, Dr. Gonzalez.
All righty. So Chris, tell us what you do. What is a PA?
So a PA is a physician assistant. We go to a special training, special school, geared in all the different specialties of medicine. We have to certify at the end of the curriculum, a board test on all different specialties. And then once we come out, there are residencies and we practice medicine in different specialties.
All right, so a physician's assistant and a nurse practitioner, the same, equal, the differences? Talk to us about that.
So similar, nurse practitioner follows the nursing module and they obtain a master's degree. A physician assistant follows the medical school program module and the didactic courses, and we also obtain our degree and certification at the end. At the end of the day, we both work hand in hand, side by side with each other, and help take care of all the patients in all different specialties.
Right, so if you're studying all these things about medicine and you're getting a medical curriculum, why not just go to medical school?
So different, at the end, we all take care of the patient. Medical school is a different frame of mind, longer curriculum than a PA program would have. So a PA program is a more condensed version of a medical school training. We have our didactics crammed in, and then we have our clinical rotations where the physician medical school is a little bit longer extended and a little bit more detailed in their education than what we do.
So in our group, you've been with us for a long time. Tell us a little bit about your career and your career as a physician's assistant and where you've had the role as a physician's assistant so that, maybe our viewers can understand all the different things that PAs do and nurse practitioners and what we call APPs.
So I was a X-ray tech and a CT tech before, thinking of becoming a PA, and I felt I wanted more of a challenge and learn more in medicine. I was more engaged. So I went to PA school, and when I got out, I was starting to work in the urgent care setting, wanting to go into the emergency room, and I had an opportunity to work for a big cardiology group, electrophysiology, interventional cardiology. Got a great deal of experience over there, and then I had the opportunity to come and work with you guys, where I've been for the last 14, 15 years, and learned a lot about general surgery, robotic surgery, bariatric surgery, and it's been a very exciting career.
And so in your daily role, let's go, what did you do 5, 10 years ago, and what are you doing now? And give us examples of what a physician's assistant could do and what a nurse practitioner could do in practice. Maybe somebody out there is thinking like, maybe, I want to get into medicine, but man, medical school, residency, it's 15 years of really, when you look at it, it's like 15 years of education,
So being a PA, you also have to have a bachelor's degree before coming into the PA program. But instead of the 4 years of medical school, it's 2 years of a PA, 2.5 years of a PA program. Nurse practitioner, similar length. So they're not short degrees, but we don't have the extended years that a physician would, and the cost of living and
the cost of education.
Cost of education much higher for you guys. At the end, we can practice in different specialties. So, for us, as a PA, we have the benefit that our curriculum covers all of medicine. So we do derm, peds, cardio, GI, pulmonary, endo, and our boards are on that topic, on all those topics. So you actually have to keep up to date with all your education, and you have to recertify every 10 years with a board exam. So the benefit to that for a PA is that, if you decide you'd like to try another specialty, that you have the core curriculum, the base knowledge to try another specialty, and then with some training with the physician or the APP that is in that specialty, you can become a specialist in that area as well with time. So that's one big benefit that being
And
a PA.
you have transitioned to a bunch of different areas, right? I mean, first you were in the office, you've gone to the hospital, and so talk to us about what you've done in transition in your career, in your PA career.
So in the office setting, we see patients in outpatient setting. We see pre-op, post-op patients, perioperative care. In the hospital, you see the acute setting, the patients that come in with an acute presentation in the OR. You get to come into the operating room and first assist in surgeries and manipulate the robot. And with time and more years experience and more dedication into your field, just as you attend many committees and part of your growth and your future, you want to be involved with those committees. That's what I've done. And following your leadership skills, became involved with a lot of the Baptist committees for the APPs, for nurse practitioners and PAs, and we've really come together and grown in the last 10 years where there is an organized committee with governance body and more of a clinical ladder and leadership opportunities. We have AVPs in the system that are APPs. So really from where we were 10 years ago to where we are now is amazing.
And so you've gone from the office setting, you were seeing patients, you've gone in the hospital, you're seeing patients in the ER, in the operating room, helping us in surgery. Now you've transitioned into a different area of your career and practice, and now you're back in the office. You were telling me you don't wear scrubs anymore. Now you're in a tie. So tell us about what you're doing now in this part of your career.
So my career elevated to leadership, and then I decided that I felt my calling after my own procedure and my weight loss and my history of my battling obesity. And I wanted to give back to the community. I wanted to give back and be able to relate my story to patients and be able to help them try to help themselves guide through the obesity barriers and tackles and try to figure out a better way of living, of trying to be healthier. So now I'm doing medical weight management for our office.
All right, so let's get into this obesity. Now we've obviously learned about physician's assistants, nurse practitioners. The question was, is there a difference between a nurse practitioner and a physician's assistant? For the patient, there's no difference.
None.
Right? Right. So the patients, whether you have a PA seeing you or a nurse practitioner seeing you, they're assisting the physicians. They're helping, complement your care. And really, for me, I can tell you, very, very, very important in our practice. And obviously, we've been able to describe all the different things that a physician's assistant could do. Now we're going to talk about obesity and medical management of obesity. So what does that mean? You're giving people medication to help them with their obesity? Is that what medical management is?
Yes, it's a combination. There are some medications now that are indicated for obesity treatment. So we follow the OMA, the Obesity Medicine Association guidelines on therapy. It's a combination of psychological, dietitian, group therapies, trying to overcome what the real problem is. It's a food addiction, overeating, and how to have best outcomes on the process.
All right, so then the question always is, what causes obesity? Is it their genes? Is it their hormones? Patients tell me it's their thyroid. Why are we obese in America? What's happened to us? You gave me a stat about how obesity is growing. What is the problem?
I don't think there's one simple answer. I think that's a very multifactorial, weighted question. At the end of the day, yes, there is a certain component of genes. There is a certain component of your thyroid and your endocrine system not functioning at its best. But at the end of the day, it's a food addiction. It's an overeating problem, and it's a behavioral problem and a relationship with food. So I think the problem stems here between these two muscles and how to understand how the brain releases chemicals and how to create better habits.
Wow, better habits. All right, so give us an example of what happens when somebody is seeking medical weight loss management. What are the things that are, you do as a physician's assistant to kind of evaluate the patient and to determine what's the best treatment for them?
So usually when they first come to see us in the office, the most important thing is listening. first we ask, if they're not coming in for obesity, we ask, is it okay to talk about obesity? Because some people don't feel comfortable on that topic. The second thing is, once they feel comfortable, if they're here to see us for obesity, we talk about, what do you think the problem is? What do you see as the patient being the problem? What have you tried before? What worked? What didn't work? And we try to listen and try to understand where the problem is really coming from. The patient will tell you they know what the problem is. They know that they're eating late at night, they're overeating, they're eating too much sugar, they're drinking too much alcohol, they stress eat, whatever I went through a divorce, I got a new job. Everybody's got the excuse of why they became overweight and why they're overeating. So listening, I think, is the most important thing. And then, repeating, acknowledging that this is what I'm understanding. This is what I understand you're telling me. And then together try to come up with a plan of how to best attack that. What are the options? Medication is not always the first option. Some people want to go on meds. They come in through the door. That's the first thing they want. And some people want to wait a little bit and want to try behavioral therapy first and exercise. And, how engaged is the person? What level are they at? And that's the most important thing, is trying to gauge how, from 1 to 10, 10 being like, I'm ready to do push-ups right now on the floor. Where are you on that path? And, it's really a lot of motivational counseling and speaking and trying to get them to buy into the process. We all know what we should do, but doing it is another thing.
All right, so you hear the patient, you understand, they understand what the problem is, but they have to be on some type of nutritional plan. I don't want to use the word diet. Though I'm going to ask you what is the best diet, because we have to understand what is the best diet out there. But they have to be on some type of nutritional plan, right? So you guys will give them nutritional counseling as well and explain to them what are the best eating habits?
Yes. So so the word diet is already set up for failure. So we never use diet.
Right.
So we say behavioral changes, making better choices, your eating patterns. So if you look at statistics, Mediterranean is supposed to be the healthiest diet, showed the best results. And what is a Mediterranean diet? Basically a low glycemic index type of a diet. So, there's no one diet, one meal regimen, one meal plan that works best for everybody. But we know that sugar is the denominator for all our obesity problems. We know that that's one of the major problems, and that it's very addicting. Just like nicotine is addicting, so is sugar. Releases dopamine in the brain, feels good, so I want to keep releasing dopamine. I keep eating the bad food.
Wow. And so are we swung the pendulum all the way back to the no sugar, like the Atkins days, where there was zero sugar and you're eating just fats and you're eating eggs and bacon? I remember those days in the 90s.
So from a medical opinion or from my opinion?
Well, you're the expert.
So I think we're behind the times. I think the Dietitian Society and everybody, that pyramid that we looked at, I think is going to change in the next 5 years. I think Atkins, when you say Atkins, people think of eating bacon all day. And
right.
Obviously, that's not healthy for us. So I think there's a balance. I think you need to eat good, clean protein, grass-fed meats, organic, avoid pesticides when you can, avoid artificial preservatives, definitely those things. I think you need some complex carbs, some good complex carbs. Avoid the simple carbs, avoid sugar at all costs as much as you can. Limit your fruit intake. Fruit is great, but people think they're eating fruit, they think they're eating healthy, but they're eating a whole bowl of watermelon and fruit and they sit at a desk all day. It's not going to be healthy. You're still secreting insulin, you're making your pancreas overwork. There's no reason for that. So there's a balance in between there, I think, where you really need to look at the glycemic index of the foods. I think that's really the key there.
And what about fruit juices?
That's the worst thing.
Yeah, I know.
So that's like that's fruit on steroids.
Yeah.
So I tell the patient, how many oranges does it take to make a glass of orange juice? Like 3, 4 oranges. You missed all the fiber and all the pulp. And so if you really wanted an orange, just suck on a wedge. You'll get the fix, what you're looking for, the sugar, the orange juice. But you got one wedge. You got a lot less sugar intake.
And I've heard that fiber inhibits a lot of the sugar absorption as well. So it's, God made the fruit in the fruit for us to eat the juice and the fruit together, as opposed to just taking the juice out, because I think the juice, like you say, is sugar. So correct eating habits. Let's call it correct eating habits. Nutritional counseling, exercise. Very important, right?
Must.
All right. So what is the best exercise?
So the recommendations are 150 minutes a week of some type of cardiovascular exercise. From studies that I've reviewed, my best opinion to patients is HIIT type of workouts, high intensity interval training type of a workout, whatever you feel comfortable. So push for 30 seconds, recover for a minute, minute and a half, push again another 30 seconds, and mix some weight training in there. Rubber bands, kettlebells, dumbbells, body weight. You got to start somewhere and then push it. And exercise is, I tell patients, so you have a food addiction, you have an addiction problem. Take that addiction out. Don't convert your addiction, which we would see in other disease processes and other people who try to lose weight. So instead of going to alcohol, going to tobacco, go to something positive. Go to exercise. When you exercise, you release dopamine. It feels good. When you see the weight loss coming off, you see your clothes fitting looser, you want to work out more. You see the results. It feels good. When you don't work out, you actually feel bad. You feel like you're missing out on something. And that's I think one of the biggest keys is teaching people how to, you get up, you tie your shoes every day, you got to get up, you got to go to do some type of cardiovascular exercise every day.
And what do you tell those patients that tell you, Doc, I don't have time. I work 2 jobs, I have kids, I don't have time.
So we all have time. It's about time management.
Okay.
So I recommend to the patients, you don't need money, you don't need anything. Everybody's got YouTube and everybody's got a TV or a phone. You go on YouTube, it's free. There's plenty of videos, high intensity, body weight only, 10-minute videos. So I said, you got 10 minutes. You can manage 10 minutes of your day to your health. You know, if you're not good for yourself, you're not going to be good for your kids, your work, your employer. You're not good for anybody. So you need to take care of yourself first.
Wow. So we've heard a lot of good information. We heard about correct eating, eliminating the sugars, that glycemic index. We've learned about exercise. Now, of course, everybody wants to be on medication, right? Everybody wants to be on the Ozempic. Everybody wants to be on the Mounjaro and Wegovy and all that stuff. So talk to us about these medications. Let's first cover, the Ozempics and the Wegovys and maybe the Mounjaro, because I know it's a mix of a couple. You're going to tell me. But what are these medications for and where did they stem from? It's always the great story of Viagra, right? Viagra has a great story. Viagra was made for high blood pressure, but it had another positive effect, right? So what about these medications? These medications were made for something else, and so talk to us about how they work.
Yeah. So when Victoza was one of the first drugs, it came out, and they don't really understand the mechanism of action of the medication. They know that it delays gastric emptying, and they saw patients were losing weight, so they were using it for diabetes, but it doesn't affect your insulin, it doesn't affect your sugar. The way I explain it to patients is, so these drugs slow the gastric emptying. When you slow the gastric emptying, you feel full for longer. The food sits in your stomach longer. You're not going to be as hungry. Your hunger hormone, the ghrelin, is going to stay more controlled, lower. All it's doing is giving you the opportunity to make a better choice. If you're not as hungry, you tend, if I taught you right and you learned and you're doing what you're supposed to, you should be making a better choice eating. If you overeat and you stretch your pouch, your stomach, you will feel nauseated, you will feel sick. So the goal is not the medication. The goal is teaching better behaviors to the patient so that they understand, I'm eating less, I'm making a better choice, less glycemic index, I feel better, I'm eating cleaner, and this drug is just helping facilitate you learning a better behavior.
So can everybody that's obese can be on these medications? Who should, who shouldn't be? There may be people listening to us and say, I want to try, but I don't know whether it's safe for me.
So that's a big controversy. There's a lot of medical weight management programs out there doing the compound medications, which are not the real medication that comes from the pharmacy. These are compounded drugs that a compound pharmacy is creating. That's not what we do at Baptist. So at Baptist, we only use the branded medications. So there are clear indications on when the medicines can be used. So Wegovy and Saxenda are used for obesity. Ozempic and Mounjaro and Trulicity are drugs that are used for diabetes. So there's very clear indications, and there's a clear BMI. 27 and above with a comorbidity, with some health problem, high blood pressure, cholesterol, diabetes, or 30 and above without one of those comorbidities.
If your BMI is 30 or above and you have no medical problems, then you can be on which one? On
Wegovy, which is a monthly GLP-1 agonist, is the name of the type of drug, or Saxenda, which is liraglutide, and it is a daily medication. Same family of drug.
Wow. So one's monthly and one's daily.
Yes. So daily was out first, and then Wegovy is the newer kid on the block that came to 1 week.
All right. And so these medications are safe. Are there problems with these medications?
So there are clear reasons not to give them. Somebody who has Men's 2 disease or syndrome, or somebody who has chronic recurrent pancreatitis, or somebody with a family history of medullary thyroid cancer, these patients should not receive this medication, because there was a profile that a rat in the studies had developed medullary thyroid cancer. Medullary thyroid cancer is a very rare form, as you know, of thyroid cancer. And Ozempic, which has been out for 10 years, does not have one human to date that has been studied and shown to have medullary thyroid cancer. So the drug has been out for 10 years.
Right. Right. So then what happens? Do the patients always stay on these drugs? I've heard these rumors about, rebound and regaining weight. So what happens? What, as the expert in this, and you're treating these patients, do you tell the patients you're going to be on this forever? Or you're going to be on it for a couple of years until you get to your goal?
So that's the $1 million question, and nobody has the right answer.
Okay.
Social media loves to give their opinion on everything. So you're asking an obese person who was very obese and understands the disease process. We don't treat hypertension, get them at goal, and take their meds off. We shouldn't be doing that for obesity either. So I think the way we treat obesity in the next couple of years will be changing. So in the past, we only had bad drugs, not drugs meant to be long-term. Phentermine made your heart rate go up, made you have high blood pressure, not the cleanest drug to stay on a long time, caused pulmonary hypertension. So traditionally, we've never treated long-term obesity. We gave them meds, we took them off, they gained the weight, they rebounded, didn't work. Same thing, it's eating habits. So these drugs are indicated for long-term use. So they've been out for 10 years. What I tell my patients is, and there's no clear, these are all recommendations, there's no guidelines on how long they need to be on, according to the OMA. So what I try to do is extend their dosing. So instead of every 7 days, I tell them try to go to every 10 days, try to go to every 14 days. What we're trying to do is just give the patient control so that they have control of their eating habit. So if I can help them just get enough drug to control the ghrelin, that they're not starving all the time, then statistically they're going to make a better choice and keep the weight off. So we can try to titrate. Patient says, no, I want to come off. Great, come off. Your hunger is obviously going to come back a little bit. Hunger coming back doesn't equal weight gain. Hunger coming back means I'm hungry, I need to eat better food, but doesn't mean I need to go to pizza and ice cream and my bad habits, because that same thing that happens after bariatric surgery. We have surgery, the hormone goes away. A year later, the hormone starts peeking its head back in, and we got to make sure we taught the patient better habits so that they keep their weight off.
Wow, it's incredible. It's not the medications, it's all the behaviors that you can teach the patients. And that's why it's so important to have this type of program, like a multidisciplinary team, and have the experts. So as we finish, there's a couple other medications. I know there's Contrave, and Quizmia. So what are those medications that we hear about?
So Contrave is a combination drug. Both of them are combination drugs. The Contrave is naltrexone, which is an anti-narcotic drug. So you can't be taking controlled narcotics, opioids, because they will make you sick. So it's a drug used to keep you away from opioids. And the other one is buspirone, which is Wellbutrin. So the Wellbutrin, which has addictive properties in the drug, is a serotonin type of a medication. So it's helped people with smoking cessation. So the combination of the two showed to work in the reward center of the brain, help you crave the food less. If you crave it less, you want to eat it less, which is the same thing that the GLP-1s do. They're actually coming up for indications now for NASH, fatty liver disease, not non-alcoholic fatty liver, and they're also coming up with indications for alcohol abuse because they're finding that people on the GLP-1s actually didn't crave, and I see it every day. Patients come in and say, I enjoyed my glass of wine every day. You took it away from me. I said, well, you're losing weight. You're getting healthier. It's not that you can't have the wine, but
the wine has sugar.
Right.
And it makes you gain weight as well.
Yep.
Wow, okay.
And then Qsymia is the other drug, which is a combination of topiramate and phentermine. Phentermine is the stimulant, and the topiramate is an anti-seizure drug, but they showed that those two medications together worked in a way synergistically to help you with your appetite control, and patients lost weight.
Wow, incredible. So we've learned quite a bit. Not only learned about physician's assistants and nurse practitioners, but we've learned about weight management. So what piece of advice would you give somebody who's overweight out there, who's struggling with obesity, and they want to maybe start something and they're trying to decide, hey, what am I going to do? Do I do weight management? Do I have bariatric surgery? Or do I just continue eating? Who cares? I'm healthy. I'm 30 years old. I have no problems. I have no medical problems at 30. I weigh 350 pounds. What should I do? What is your piece of advice? Somebody who's been through this and been involved in this for a long period of time.
So definitely I would recommend that they go see their primary care first. And as we know, diabetes doesn't present itself in labs till 10 years after the disease was already doing some damage. So you don't wait till the problem is an official diagnosis. You see your primary, come see us, come see somebody who treats medical management of obesity. If surgery is where you think you need to, then come see us as well. And just come and at least get the information, inform yourself of what are the options. If you do nothing, what's going to happen? You will be diabetic, cholesterol, blood pressure, heart failure, stroke, heart attack. I mean, they all come. It's just a matter of time.
Yeah.
So getting to it and being proactive and getting it ahead of time, I think is really the key.
Wow. And, eating correctly, good food choices, exercise, moving. What great advice. So, Chris, thank you. Thank you for the 14 years you've been with us, and thank you for helping our patients. We've learned quite a bit today here on the Miami Community Health Show, learning about our nurse practitioners, our physician's assistants, and how they help us daily and help you as patients. And we've learned also about weight management and how these medications and these changes in your lifestyle as well as your activity can help you control your weight. So once again, Dr. Anthony Gonzalez from Miami Community Health recommending that you be healthy, take care of yourself.